so I'm Associate Professor Debbie Leach, and I'm in the emergency department. I'm an emergency physician. I think there's been a tremendous change, particularly over 20 years, but certainly in the last few years, there's been a worldwide recognition that the patient voice needs to be heard, and that this makes the journey safer for the patient and a lot more satisfying their experience of care. And so I think everybody is more aware of this, and there's a desire to bring the patient into the conversations that we have and to include their thoughts and views on their treatment as well. So in ED, we've done a number of different things. We've had quite a strong focus in our short stay unit, which is a 20-bed unit for patients staying up to 24 hours. And last year we introduced a new project of sharing our medical notes with the patients on arrival to short stay, and this was very popular with patients. So at the outset we undertook a focus group and showed a group of patients what notes and what pieces of communication were available and that they could see if we were going to share them, and then we undertook a study where we did share them. We haven't published yet, but the results were that patients were very satisfied with that process. It basically moved patients from being satisfied to quite satisfied to being very satisfied or satisfied. So it moved everybody up the curve of satisfaction. The other thing that we did was to introduce a multidisciplinary ward round. So now nurse, doctor and patient all contribute to the ward round process after handover in the morning. And that's also been felt to be a very positive thing, both from a staff perspective and also, we hope, from patient perspective. The thing that I've been most proud of in the ED over the last few years is our teamwork. Our strength of our teamwork has been really good. The leadership course that we've undertaken, the projects that people are undertaking, our morbidity and mortality meetings, multidisciplinary, and the level of cooperation together, I think, is producing great things. One of the things that we do in each ward, including the ED, is to have a huddle, and that's done several times a day, once a shift. And it's just the senior people on the floor in the ED get together around a board and go through a set list of parameters. We look at our performance for the day, we look at any issues for any patients, any instances of harm that have happened, or any operational problems within the ED. And we can then escalate that up and it gets dealt with in a really timely way. And the other thing that we do on that is to celebrate staff. The success of the model is about having staff at the ground roots level involved in the model, aware of it, and to be able to channel their good ideas. So here in ED we've got a redesigned team, and we very much do our own local improvement work. So we think of some ideas and then enact them through a group. So we have project teams. And I think it's empowering people and giving them the resources and giving them some expertise to enable that change to happen. We've got a number of ideas. Probably the most successful idea we've had is the No Unnecessary Tests project. Now that did attract funding, but we were doing this project for a few years with minimal resources, trying to cut down the unnecessary tests that are happening in the emergency department. And this has got a big impact on patient care and patient experience. Unnecessary blood tests, radiation, cost and worry. So we've done quite a lot of work on that and reduced tests. So how we know we're making a difference in our No Unnecessary Test project was with the measurement of the decreased testing that we were doing. So on a range of blood tests such as CRP, venous gases, clotting, calcium magnesium phosphate, all of those tests in the emergency department were reduced by 50%, roughly. The CTPA testing was reduced by a similar amount, and we've also undertaken a project with the orthopaedic unit looking at CT limbs, and we've reduced that by about 10 to 15%. I've got a very sad story actually of a patient who came into our department a couple of years ago with vertigo, and she was very unwell, and she went to the short stay unit and ended up being misdiagnosed. So people felt it was a benign cause of vertigo and she was discharged home. But unbeknownst to us, she had a stroke, and it was an unusual sort of stroke, and she ended up coming back to us and then getting admitted to the ward. The family were very upset and were really unhappy about the experience that they'd had, and they felt that we hadn't listened to the family about what this lady was like in her normal life. And since that time, they've had to come back a few times, and they said to me just last week that they've noticed a real change in what the atmosphere and what the patient experience is like and how staff are treating people. They felt more listened to. They felt like people were taking a little bit more time and care, listening to the story and involving the patient in their in the planning process.